Hi, my name is Miguel Mendoza. I'm studying medicine. I'm in 8th semester, and in this video I talk about decolonization and to reduce post-discharge infection risk among Mrsa carriers. Definition. The methicillin-resistant Staphylococcus aureus is the most common cause of skin, soft tissue, and procedure-related infections. Approaches to MRSA have included education about both hygiene and environmental cleaning, as well as decolonization with nasal uh, mupirocin and chlorhexidine with chlorhexidine antiseptic, but to reduce courage and prevent infections. Decolonization has reduced the risk of surgical sites infections, recurrent skin infections, and infection in the intensive care unit.
I don't really consider that culturing the nares alone is sufficient to look for hidden areas of staph, particularly in patients who have problems with recurrent Mrsa infections. Studies done in Europe and the United States indicate that the throat is a common source of Mrsa and that the organism can stay there without causing symptoms and ultimately cause Mrsa to spread out on the skin and then be the source of recurrent problems. In addition to the throat, intertriginous areas of the skin, warm, moist areas, under the armpits, in the gluteal cleft, and areas like that can also harbor Mrsa silently, so that culturing just the nose really doesn't reveal all the places where the organism might hide. And if you don't find it in the nose, then the tendency is not to do decolonization. The answer is that an American study showed that 12.5% of those who were harboring Mrsa harbored it only in their throat and not in the nares. So not finding it in the nose doesn't mean it's not being carried somewhere as a source of recurrent infections. So that's why it's so important to culture not only the nose, but also the throat and typical intertriginous areas. So to decolonize the throat, one uses a chlorhexidine mouthwash that's commercially available, and it should really be done 3 times a day for a week, each week per month for roughly 3 months if a patient's really had significant problems with recurrent Mrsa. I might add that in addition to decolonizing the nares and the throat, it's probably a good idea in patients who've had really severe recurrent Mrsa infections to try and decolonize those intertriginous, warm, moist areas, and that requires a bleach bath done probably 1 or 2 times a week over the course of about a month. If you add decolonizing the nose, the intertriginous skin, and the throat together, that becomes quite burdensome in point of fact. And it should only be done in those patients who had significant recurrences of major Mrsa infections. I wouldn't do it when someone has a single episode, but if they've had recurrent problems and they've been counseled about proper hygiene and their close personal contacts have been screened and they're still having a problem, that's when I go to full-out decolonization.
Application in medicine. Maintain basic hygiene, antisepsis measures with all residents, colonized or not, and in some cases measures of insulation of the person to prevent the spreading of Mrsa to others resident or health personnel. Apply standard measures and situations involving contact with blood, body fluids such as semen, vaginal secretions, cerebrospinal, synovial, pleural, peritoneal, and pericardial tissues and fluids. Barrier systems, masks, gloves, should be used routinely to prevent skin and mucomembrane exposures when contact with blood or body fluids and any residents is anticipated.
Okay, we are going to go over our new Mrsa decolonization protocol with the CHG wipes and the Mrsa ointment to the nose, otherwise known as Bactrim. What's going to happen is once your patient is identified as Mrsa positive and he meets all the criteria, which is at least 32 weeks gestation or 30 days or older and weighs at least 1,000 grams, then we can proceed with the CHG bath. What's going to happen is this lovely warmer right here is going to be kept in the clean utility room across from our Mrsa cohort. Inside there are 3 different lights that will come on. A green light will come on when the wipes are ready. A red light will come on when you have to dispose of the wipes. And a yellow light comes on when the wipe is still in the warming process. These wipes are only good for a maximum of 3 days once they go in here. So the plan is for day shift, when you know that your patient will be getting a decolonization bath, you will be putting the wipes in here so that for night shift, they will be ready so they can use them at any point during their shift. Okay? When you open this, you're just going to reach in and take out the wipe, and then the light will go off, saying that you removed it. So once you take this out and put it at your bedside, you don't want to put it back in for a couple of reasons. Number one, because it's been in a patient that is Mrsa positive room, and number two, if you put it back in, it thinks it's a new wipe. And remember, they're only good for three days. All right, so we're going to get our wipe, and we're going to go into our patient's room. So you get gowned up here. Once we are ready to go, we're just going to open the package, and it just tears open easily from the back. Literally just rip it right down the back. Inside there is an absorbent pad that we can just toss, and then there will be 2 wipes, and we are going to use both of these wipes. The first wipe you are going to use from the jawline down to the waistline. The second wipe will be used from the waistline down to his toes. Okay, so we are going to start with the neck area. You do not want to go above the jawline with these because they can be dangerous if they come in contact with the eyes or with the ear canals. So we're going to start with the neck. And remembering the babies that are a little chubby or edematous, you're going to really have to get in those folds. You want to apply a little pressure when you're cleaning. You're going to come down over the arms. Make sure that you get under that armpit really well. Come down the arms and do each individual finger. Then we're going to start on the other side. Same thing, shoulders in that underarm area, down the arm, and each individual finger. As you work your way down the body, if you come across a device, this can go over the device dressing, and then you want to go out 6 6 inches away from the patient and clean to get rid of any MRSA that is actually on the device. All right, now that we've done the front, we need to do the back. You can just set him up to do the back, or if he's vented, just roll him on his side. Same thing, make sure you get in all those folds, go all the way down his back. Now, we do need to let this dry. If you wipe it off, it becomes inactive. It can take up to a minute to dry. It may feel a little sticky as it dries, but once it dries completely, it will not be sticky anymore. So we're going to say that this is dry, and we're going to move on to our lower extremities. We're going to get our second wipe. We're going to start with his legs, and again, make sure you get in those folds and creases. We're going to do all the toes. Same thing on the other leg. Now, if he has a messy diaper, clean it the regular way and then use this. But once we get this open, you're going to make sure you get in that big crease right where their tummy hits their low abdomen, I guess. You're going to make sure you get in the creases of their thighs, especially those edematous babies. Remember, they're really hard to get into sometimes. You can use this right over the entire diaper area. If they have a bad diaper rash, obviously you're not going to want to use these. Just going to continue to clean, and again, we have to let this dry. Now, the other secret to this bath, not only can you not wipe it off or rinse it with any type of water, you can only use compatible lotions with this, and the lotion that we can currently carry is compatible with CHG, and it says so right on the front of the container. So if your baby has special smelly lotions, they will not be able to use them for the 5 consecutive days that they'll be getting this bath. So once this bath is ordered, if it's ordered on a Tuesday, they'll get bath Tuesday, Wednesday, Thursday, Friday, Saturday night, along with the Mrsa in their nose twice a day for the Mrsa. You're going to put some on a Q-tip. It's going to go in their nostril, turn it around, and then just kind of squeeze the nostrils together to make sure you get it in there. That will happen twice a day. The bath will happen once a day. The diaper area, if the baby soils, once the baby soils his diaper, you are just going to clean it the regular way. You are not going to reapply the CHG each time. Once the baby has had his 5 consecutive days of decolonization, they will start to send weekly surveillance cultures again. If he has 3 negative surveillance cultures, he can move out of the Mrsa cohort. I would ask the parents, when we start the decolonization process, to take his belongings home and wash them in very hot water, because if we just take them out of the bed and then put them back in the bed, we're just going to put Mrsa right back in there. So once he gets out into the regular population of the NICU, he will continue to have his surveillance cultures. If at any time he comes up Mrsa positive again, he will be moved back to the Mrsa cohort area. And that's how we're going to do it.
Wait a minute, where am I? Alright, let's start this again. I just took another video. Oh.
Pros and cons. The pros: successfully prevents the disease during temporary high-risk circumstances, recurrent skin infection, UCI care, arthroplasty, and cardiac surgery. And the cons is produce local irritation.
All my videos and this video is for educational purposes only. Please consult your doctor before you make any decision about your medical care.
Issue applied in Ecuador. Age more often MRSA positive cases was 16-18 years, predominance in males with the primary infection were abscesses in the 66%, and blood cultures 16%. Most cases occurred in a specialty service and vascular surgery, approximately 20%, and internal medicine 28%. Vancomycin sensitive was 100%, as linezolid and tigecycline. So the decolonization protocol must be structured. This is a study of the Central University of Quito.
Staph aureus is a very common bacteria that actually about 1/3 of people carry around on their skin or in their noses. What MRSA is a certain subtype of that bacteria that has developed a resistance to the most common antibiotics we use to treat the staph infections. The bacteria itself continues to evolve and become more resistant. So every time we find a good antibiotic that works against it, the bacteria gets smarter and starts to develop resistance against that antibiotic as well. It can be spread through direct contact of a wound. So if you have a wound that is infected with Staph aureus and you touch that wound, it can be spread in that way. The same way if someone is in the public who has a wound that's infected with Staph aureus, they touch that wound and then they touch, a chair or a doorknob or anything along those lines, it can be spread in that manner as well. For those who are carriers of the bacteria, they have it on their skin and in their nose at all times, they can also spread it to other people. Symptoms of a staph infection or an MRSA infection are typically in the skin and soft tissue. It can start with what looks like a spider bite, but unless you actually see the spider bite you, you'd never want to assume that's what's going on with your skin. So it can be an area that looks like a bug bite or a wound that is formed there, and then it will get more red and more swollen. It's often painful to the touch and warm to the touch, and it may start draining pus or some other type of fluids, and you may have a fever as well with the skin infections. When it comes to the skin infections, if there is what we call an abscess there, or something that is a fluid collection, a collection of infected fluid, it may need drained with a surgical procedure. Sometimes that can be done at the bedside with just a local anesthetic or a local numbing agent. And then sometimes if it's a large infection, you will have to go to the operating room to have it drained. Staph or MRSA can also cause pneumonias. So symptoms of a pneumonia would be fever, cough, chest pain, shortness of breath. It can also cause bloodstream infections, which the symptoms of that are a little bit more vague. You often just feel tired, run down. You'll have fevers and chills, but no specific symptoms to the bloodstream infections. Antibiotics are still our #1 treatment of these infections. For pneumonias and the bloodstream infections, you may need to be hospitalized to have supportive care with oxygen or breathing treatments while the antibiotics are starting to work. After you've been on the antibiotics for about 48 to 72 hours, you're going to feel significantly better. We often see changes in the skin infections within 12 to 24 hours of starting the antibiotics. There's nothing dramatic that you have to do to try and prevent it from recurring. Common personal hygiene behaviors will help prevent the spread of MRSA. Washing your hands, not sharing personal hygiene products like razors and towels, washing your bed linens, things like that, and keeping any wounds that you have clean and covered, and washing your hands after taking care of wounds.
In conclusion, in patients with MRSA, a positive culture would have been randomly assigned to undergo decolonization with tropical chlorhexidine and mupirocin for 6 months after discharge, had a lower risk of MRSA infection from any cause, and hospitalization over the 1 year after discharge than those who had been randomly assigned to receive hygiene education only.
Hi, I'm Dr. Amy Meditz. I'm an infectious disease specialist at the Beacon Center for Infectious Disease at Boulder Community Health. Today we're going to talk about a bacteria called methicillin-resistant Staphylococcus aureus. This is commonly referred to as Mrsa. Mrsa can cause infections in different parts of the body, including the skin. Mrsa infections can range from being very limited to very serious. What makes Mrsa different from other forms of staph is that it cannot be killed by a number of commonly used antibiotics. This has led to this organism being called a superbug in the media. It's important to know that there are treatments for Mrsa, and we commonly take care of this infection at the Beacon Center.
Hello, my name is Dr. Todd Turner. I'm going to explain an important concept called Mrsa colonization. Mrsa is a very common bacteria. In the majority of cases, Mrsa does no harm to the colonized person. However, a person colonized with Mrsa can spread the bacteria to other people through direct contact or by leaving the bacteria on commonly shared surfaces. Sometimes, a person colonized with Mrsa will develop an infection. While there is not always a clear-cut reason as to why this happens, people who have recently been hospitalized, who have an underlying illness, or who have been recently taking antibiotics are more prone to infection. Good personal hygiene can reduce your risk of infection. Maintain good hand and body hygiene. Wash your hands regularly with soap and water. Avoid sharing personal items such as disposable razors, linens, and towels. Keep kitchen and bathroom surfaces clean. If you think you may have an infection, don't delay treatment. It is also very important that you complete all the antibiotics that your doctor prescribed to you for your infection.
Hello, my name is Dr. Mark King. I want to talk to you about common conditions caused by MRSA or Mrsa. Mrsa commonly causes skin infections such as folliculitis, cellulitis, or soft tissue abscess. Folliculitis is an infection of the hair follicles leading to skin irritation, and cellulitis is an infection of the skin and underlying tissues as shown in these images. Mrsa infection can also lead to the formation of an abscess or collection of pus that builds up within the affected tissue. At times, Mrsa can cause serious infections such as skin or wound infections, pneumonia, or infections of the blood. Once Mrsa invades the bloodstream, other structures within the body, such as joints, the spine, or the heart, can become infected. On very rare occasions, Skin and soft tissue infections can become very severe and progress rapidly, requiring surgery or a stay in the hospital.
Hi, I'm Dr. Rao. I'm here to talk to you about treatment options for MRSA infections. Treatment can take place in a variety of healthcare settings. Abscesses caused by MRSA can be drained by a surgeon or in the emergency room or urgent care center. Some small abscesses can be completely treated by drainage alone. Most of the time, antibiotics are also needed. While MRSA is resistant to several common antibiotics, there are several options that retain the ability to treat it. The length of treatment depends on the type and extent of your infection. Occasionally, if the extent of infection is too great or an individual has specific allergies or intolerances, intravenous antibiotics may be necessary. It is not uncommon for a person to experience a recurrence. If your infection returns, we may try various topical modalities to try to reduce the amount of MRSA on your skin or mucous membranes.
Thank you for watching our video on MRSA. We hope you have a better understanding of colonization, disease, and treatment of MRSA. At Beacon Center, we are happy to address any issues with MRSA. Call us at 303-415-8850 to make an appointment with one of our providers.